Welcome to AETCM, the emergency medicine channel. Today let us discuss about pulmonary embolism. Pulmonary embolism means there is an obstruction in the pulmonary artery or its branches due to materials like thrombus, tumor, air or fat. It can be originated any part of the body like upper limb or lower limb, wherever it is. It can travel to pulmonary circulation, first to the right heart, then to the pulmonary circulation, and it can produce block. The commonest cause for pulmonary embolism will be a DVT, deep vein thrombosis, especially in the lower limb. It can happen in the upper limb also, but most common problem is DVT in the lower limb. From there it will get dislodged, and through IVC it will reach the right atrium, then right ventricle, then to the pulmonary circulation. Or paradoxically it can come through foramen ovale or atrial septal defect. That is not very common nowadays, but it can also happen. So here is the circulation from the lower limb, or from here the clot can travel and reaches through the IVC, it will go to the right atrium, then right ventricle. From there it will go to the lungs and it can block somewhere in the pulmonary circulation. That produces something like this. So there is a block here, all these arteries are blocked. So this part of the lung is not getting adequate blood supply. So pulmonary embolism can happen. Now there are different types of pulmonary embolism. One is acute pulmonary embolism. Suddenly patient develops obstruction in the pulmonary vessels, and sometimes this patient can have cough, breathlessness, hemoptysis, hypotension, shock, all these things. Some patients it takes time. Repeated pulmonary embolism can produce subacute or chronic pulmonary embolism. That mainly happens in patients who is having hypercoagulable state or malignancy, and sometimes it can lead to pulmonary hypertension also. Now, there are a lot of risk factors for pulmonary embolism. The most common risk factor is the prolonged travel or immobility. That is the most common. Then that can create DVT. From DVT it can produce pulmonary embolism. Other than that, obesity, smoking, surgeries and trauma, that is also prolonged rest, hormonal replacement therapy, oral contraceptive pills, antiphospholipid antibody syndrome, malignancy, old age. These are the risk factors. Some important risk factors, they are inherited, that is factor V mutation, antithrombin 3 deficiency, protein C, protein S deficiency. So these are the common causes, but the most common cause for pulmonary embolism and DVT is prolonged travel, immobilization, post surgery and trauma, complete bed rest. Now from all these foci, like whether it is fat embolism due to a fracture, amniotic fluid embolism in pregnancy, tumor embolism due to malignancy, gestational, that is hydatidiform cyst, then endocarditis, septic emboli, hydrated cyst in liver, IV injections, central venous cannulation, all these things can produce emboli due to various reasons. Here it is fat embolism, in fracture it is fat embolism, sickle cell anemia, it is sickle cells and infarction crisis, amniotic fluid, tumor cells, trophoblastic material, bacteria, fungi in septic endocarditis, hydrated cyst, foreign material during injections, air embolism. All these things can go to the right atrium through the IVC. It will go to the IVC, then right atrium, then right ventricle. From there it will go to the pulmonary circulation. Okay. So that is a most common route. Now what are the clinical features? If somebody comes with acute onset of tachypnea, hypoxia, cyanosis, tachycardia, there are differential diagnoses for acute breathlessness. It can be due to asthma, COPD, pulmonary embolism, pulmonary edema, foreign body. All these things are the common causes for acute breathlessness. In one of the important causes, pulmonary embolism. So, acute tachypnea, acute breathlessness is the most common finding. They also can have hypertension because if there is an obstruction in the lungs, so from right ventricle blood is pumped to the right ventricle and there is complete obstruction there, there is a large pulmonary embolism. From there it has to go to the left ventricle, from left ventricle only then further pumping will occur to systemic circulation. So, if there is an obstruction in the pulmonary circulation, patient can have hypertension, shock, all these things. So, hypertension due to RV failure, elevated JVP, loud P2, acute cor pulmonale, acute right ventricular failure, low grade fever. Symptoms like previous history of DVT, sudden chest pain, cough, hemoptysis, pleuritic chest pain, syncopal attack due to hypertension, all these things also can occur. Mortality rate is somewhere around 30% without any major treatment. Now, acute pulmonary embolism causing pulmonary vascular obstruction, these are the problems are going to occur in the patient. So, it is mainly the problem is mainly in the right ventricle. Right ventricle is dilated, that can produce reduced pumping, that explanation is given in the previous slide. On top of that, right ventricle when it is dilated, your right ventricular septum can move towards the left ventricle, that itself will reduce the compliance of the left ventricle. So, that also happened, and major part of the lung is not having any blood circulation, that can reduce the oxygenation. So, ventilation perfusion mismatch can happen, and because of this RV failure and RV dilatation, patient can develop atrial arrhythmias like atrial fibrillation, multifocal atrial tachycardia, all these things can also happen. Now, there is a scoring system called as Wells score or modified Wells score. Whatever we are told, that is put in this scoring system, and depending on these parameters, you can see what is a score, final score is given. If the score is more than 6, there is a high possibility, 2 to 6 moderate possibility, less than 2 it is a low possibility. Simplified or modified Wells criteria, if it is more than 4, pulmonary embolism likely, less than 4, pulmonary embolism unlikely, that is also there. Now, there is another criteria called as pulmonary embolism rule out criteria. PERC includes 8 factors: age less than 50, pulse rate less than 100, just opposite of previous one, oxygen saturation good more than 94, no unilateral leg swelling, that is DVT is ruled out, no hemoptysis, no surgery trauma in past 4 weeks, no previous DVT or pulmonary embolism, no oral hormonal use or oral contraceptive pills. Patient fulfilling all 8 criteria is considered as negative for pulmonary embolism. So, here it is a negative predictive value. To rule out pulmonary embolism, this is called as PERC criteria. Now, what are the investigation you do in pulmonary embolism? Everyone tell plasma D-dimer. Okay, it is not like that. Plasma D-dimer can be elevated in so many conditions, including pulmonary embolism. It can be elevated in sepsis, infarction, myocardial infarction, stroke, pneumonia. But if but in a suspected case of pulmonary embolism, if plasma D-dimer is negative, you are suspecting pulmonary embolism because patient is having breathlessness, some pleuritic chest pain, you are doing D-dimer, and if it is normal, then you can rule out pulmonary embolism. So, it has got a negative predictive value, that is very important. Negative predictive value for pulmonary embolism is very, very important. If the patient is on anticoagulant also, D-dimer may not be positive, that you should remember. ABG, there will be tachypnea, so carbon dioxide washout can be there, so CO2 will be reduced. Because of the pulmonary embolism, the mechanism what we have seen previously, oxygenation is reduced, so you can get low oxygen also. So, both PO2 and PCO2 initially will be low. ECG, the most common finding will be sinus tachycardia, atrial arrhythmias like atrial fibrillation, right bundle branch block because of the right atrial and right ventricle enlargement, right RVH pattern with strain can be there. The most classical finding is S1, Q3, T3 that we will see the next slide, but it is not very common in common pulmonary embolism. The most important finding in any pulmonary edema, pulmonary embolism will be tachycardia. That is a non-specific finding. Now, this is S1, Q3, T3. Lead 1, there is a deep S wave. So, this is S wave. Lead 3, there is a Q wave. First negative deflection is Q, second negative deflection is S wave, and S1, Q3, T3, inverted T wave in the lead 3. Okay. So, these are the common classical finding in pulmonary embolism, but you may not see in many pulmonary embolism cases. Now, chest X-ray, there are different signs like Westermarck sign, oligamy in the lung fields, elevated diaphragm, wedge-shaped pulmonary opacities, that is Hampton sum, pleural effusion, enlarged pulmonary artery. All these findings can be there in chest X-ray, but the most of the time when you follow pulmonary embolism cases in a series, you can see that most of the cases the X-ray will be normal in pulmonary embolism. Echo, one important finding you can see, that is RV dilatation. Increased RV size and decreased RV function. These are the two important findings you can see in massive pulmonary embolism. Tricuspid regurgitation can be there because of the RV dilatation. Abnormal septal wall motion, RV wall hypokinesia, interventricular septal flattening, and sometimes it can be bulged towards the LV side. McConnell sign is regional wall motion abnormalities that spare the right ventricular apex. So, here wall motion abnormality is there, here it is normal. Right heart thrombus also can be there in some cases. Other imaging techniques, ventilation perfusion scan is there, chest CT with contrast, MDCT chest is there, color Doppler of the neck vein to rule out, leg vein to rule out DVT. But the gold standard investigation in pulmonary embolism is CT pulmonary angiography. So, you can see in CT pulmonary angiography, in the lungs there will be multiple blood vessels in the lung, one of the vessel will be blocked. So, after that there is no supply. So, that is the advantage of CT pulmonary angiography. But if the patient is having renal failure, we cannot give contrast, pregnancy. Then another important investigation is VQ scanning, ventilation perfusion scanning. So, here in lungs what is happening is ventilation in pulmonary embolism, the air is coming well, ventilation is good, but blood vessels are blocked. So, ventilation good, perfusion bad. So, VQ ventilation perfusion, VQ is ventilation perfusion scan, VQ mismatch, ventilation perfusion mismatch. Whereas in pneumonia, ventilation is reduced, perfusion is good. There also you get ventilation perfusion mismatch, but here ventilation is good, perfusion is bad. Now, this is a CT pulmonary angiogram. You can see CT angiogram showing multiple pulmonary artery filling defects. These are filling defects. What you are seeing here is filling defect. Here also you are seeing filling defect. Filling defects arrow consistent with pulmonary embolism. After that, the supply will be reduced. Ventilation perfusion scan, I have already told, young patients, pregnant with a history of contrast medium induced anaphylaxis or allergy, patient with severe renal failure, all these conditions you cannot use the CT pulmonary angiogram. Here we have to use VQ scan. So, this is the algorithm which will help you to make a diagnosis of pulmonary embolism. So, history assessment, all these things should be done in emergency room. ECG can be taken, ECG may show finding, X-ray may show finding, but if D-dimer may be positive in pulmonary embolism, then finally you have to go for CT pulmonary angiogram to make a proper diagnosis. Now, procoagulant workup, whenever there is a unprovoked pulmonary embolism or DVT, like patient is not having any travel history, not on any drugs, hormone replacement therapy is not there, then you have to go for procoagulant workup. So antiphospholipid antibodies, plasma homocysteine, PNH should be rolled out, factor 5 PCR should be done, prothrombin 3 should be done. But remember, protein C, protein S, antithrombin, these are the three investigations that also should be done. But whenever there is an acute thrombus in any of your artery, to lyse these thrombus, our protein C, protein S, and antithrombin 3 will be utilized. So the levels will be acutely low. In any embolism or any infarction, the levels can be low. That doesn't mean that this patient is having deficiency of these proteins or okay. So whenever you see that these investigations are showing lower results, then you have to repeat it after some time. If the reports are normal, no need to worry, no need to repeat it. If they are very low, don't think that this patient is having protein C and protein S deficiency or protein antithrombin 3 deficiency. You have to repeat the test after 6 months. Initial management, ABC should be taken care. Morphine can be given, but morphine sometimes can produce hypertension. Pain, you can try adrenaline or something. Hypertension, that we have already seen, that should be treated with fluids or noradrenaline. Dopamine should be started after noradrenaline and cardiogenic shock. Fluids are the mainstay treatment in pulmonary embolism induced or RV failure induced hypertension. Heparin can be started in most of the conditions, but if the patient is having hypertension, shock, or massive pulmonary embolism, it is better to go for TPA. That will afterwards. Heparin dose is 80 milligram per kg IV stab and 18 milligram per kg body weight. Antithrombotic therapy, heparin or warfarin can be given. Along with heparin, warfarin has to be started. Heparin 80 units and 18 units. PPTT should be monitored. You can, instead of heparin, you can go for long molecular weight heparin. So no need to monitor the PPTT or ornopanax can be given. Along with that, you can start warfarin in a dose of 7.5 to 5 milligram and taper the dose according to the INR. You have to keep the INR around 2.5. After 1 week, we can stop heparin and continue warfarin at least for 6 months. If there is a reversible cause for DVT or pulmonary embolism, 6 months, and we are not able to find out the cause or a genetic cause is there, it has to continue lifelong. Thrombolytic therapy, if the patient is in hemodynamic instability, large thrombus, then you can thrombolyze the patient. The most commonly used drug is another activator. Those that can be given. Massive pulmonary embolism, hypertension, shock, all these things we have to try this. And initially 10 mg bottle, then 90 mg infused over 2 hours. Streptokinase or urokinase also can be tried. Embolectomy is indicated in patients with hemodynamic instability or some related contraindication for thrombolytics. And if thrombolysis fails also, you can use it. What we have discussed is pulmonary embolism, one of the most common conditions which can produce acute breathlessness with hypertension. There are multiple other reasons also for that. But patient who had travel history, patient is on long-term hormone replacement therapy, or congenital disorders like protein C, protein S, all these conditions got here expressed in the previous slides. They come with acute onset of breathlessness. You are not able to find out anything. X-ray is normal, ECG is normal. Then you are strongly thinking about pulmonary embolism. D-dimer is a very good investigation to rule out pulmonary embolism. Ideal investigation to diagnose pulmonary embolism is CT pulmonary angiogram. Echo is also a very good tool in analysis, but it will pick up only some pulmonary embolism related features. The feature will be right ventricular dilation that can be picked up by TTPA is the ideal treatment. Thrombolysis is reserved for patients with massive or hemodynamically unstable. Repeated pulmonary embolism due to tumor or something like that, you can even go for